right? That's simply because the devil had put you before the Lord in question. And how he did it? He said, have you considered my servant Huge? Have you considered my servant Emil? Have you considered my servant John? Right? And God then say, you could go this far, but that's all. As we continue our walk, as we continue our growth with God, let us continue to trust him. And for sure, even though the trials come, even though the obstacles come, even though the challenges come, we will could say to ourselves, we know that we are in the hands of God and he will continue to carry us. He said in his word, my last text, I will never put more on you than you could bear. And if you trust God and you believe him, you could take that assurance, like the old colloquium they say, you could take that to the bank. But you could take that and stand on that because God himself said, I change not. Let us be blessed as we go into this service and as we hear from the professional to encourage us to maintain and to continue to be healthy and live healthy in Christ. Amen.
Amen. Amen. Thank you, Elder Paul, for a timely and excellent devotional. I just remember we used to always say that, you can take that to the bank. And, whenever God gives you a guarantee, you definitely can take that to the bank. So if we do our part, he will do his part, and we can definitely live in health as he wants us to. Thank you again very much. Okay, so we are going to move on. Just before we continue, we just like to recognize some of our persons who are on the call with us today. Of course, our devotional speaker, Elder Paul, is joining us from Low Sound in Andros. We have persons on the call. I think this is our first person from Turks and Caicos Island. Of course, many of us are from New Providence. We have Grand Bahama, Cat Island in the house. And so definitely we're very, very happy that all of you are joining us. And as persons continue to join, we will also recognize them. Now, at this time, since this is our first meeting for 2026, one of the things we want to do is reaffirm or renew our commitment as to why we even have this platform to begin with. And so, we're focused on looking at preventing amputations and complications in persons with diabetes who are living with diabetes, especially lower extremity complications. We want persons who have diabetes to live well and to have their feet for life. And so that is what our vision and focus is on this platform. If you have been joining us for a while, I am sure you are very familiar with the statistics that has galvanized us to even form this platform. And some of them are over 589 million adults are living with diabetes worldwide. 90% of them are type 2. About 20% of our population here in the Bahamas is either impaired glucose, meaning the sugar is high, or have diabetes. A specific 11.8 have diabetes, and the other ones have impaired glucose. About 25% of the persons who have diabetes will have a foot complication at some time in their life or an ulcer sometime in their life. Every 7 seconds, someone dies from diabetes. Every 20 seconds, someone gets an amputation. So you can see from this information that we really, really, really need to do something. And for the past 3 years, I guess maybe 4 years now, we have been having this monthly meeting here on our Zoom platform and also sharing the information with persons who are joining us and also with those who are unable to come at this time. Well, this evening we have an awesome speaker and a very, very good friend and colleague of mine. And we are very pleased that she is here with us tonight. So, our speaker is Dr. Shanika Hill. And mostly I don't think she's a stranger to a lot of us because, as we know, she is really the brainchild and the foundation of our annual Foot Fest and Bowery Mission Trip, where thousands of persons receive free podiatry care right here in New Providence and the Family Island. So we call her honorary Bahamian because she's been here for the last 4 years, I guess, every year. And when she comes, she takes it by storm and makes sure that everything is done in order. So Dr. Shanika Hill is a podiatrist. She is from Bowery University. She was serving as the clinical dean and for the students at Bowery University, the podiatry students. And she's also in private practice in the Miami area. Now, she's very passionate about education. And another thing she's passionate about is helping the underserved population. Every time she speaks, she talks about persons that she see who, maybe don't have insurance or don't have a lot of means like that, but she's passionate about doing everything she can to save them, to have them save their feet. Now, our focus this evening is talking about limb salvage. Limb salvage just means saving the legs of persons or the lower extremity of persons, preventing amputations. And we say it like this: saving limbs or legs saves lives. And so that's why the focus is on that. And that's why we're doing this topic at the beginning of the year, because we want everyone to know that that is what we're all about. We're trying to save limbs and we're trying to save lives. And so now help me welcome my friend and our speaker this evening, Dr. Shanika Hill.
Thank you so much, Dr. Mitchell. Can you hear me okay?
Yes, we can hear you. You can do maybe just a little bit louder, but we can hear you.
Perfect. Okay. There might be a little bit of background noise. My apologies. I will try to speak louder for everyone to hear me. All right. Thank you so much for that kind introduction. I do hail from the Miami area, but I am fortunate enough to actually be in the Bahamas at the moment. It's been a rainy day today, but it doesn't matter. The Bahamas is very dear to my heart, and I love being here and giving back to the community of the Bahamas as much as I possibly can. So as Dr. Mitchell mentioned, we're going to talk a little bit about limb salvage today. So I am going to share my screen and pull up my PowerPoint. One moment, my apologies. Here we go. All right. Can you see my screen okay?
Yes, we can.
Perfect. All right. So the topic today is going to be innovative approaches to limb preservation, non-surgical strategies in a limited setting for modern techniques advancing care despite resource constraints. As Dr. Mitchell mentioned, my focus is more in areas that are underserved in minority areas who have low insurance or even no insurance population because the disparity shows that they have the highest percentages of limb loss, leading to high amputation rates, which can cause significant complications in the future. And I'll discuss those in just a moment. So these are just the objectives of what we're going to discuss. We're going to talk a little bit about what epidemiology is, kind of globally, and globally I mean across the world, and we're going to focus on limb loss in the underserved area. We're going to talk a little bit about some cost-effective diagnostics and treatments, and identify some affordable non-surgical tools. We're going to talk a little bit about interdisciplinary collaboration. If I have any healthcare folks on the line, we'll talk a little bit about the importance of multidisciplinary teams teams, why it's important to have different types of specialists on the case of diabetic ulcers. And then we'll talk a little bit about prevention and patient education, which for you all, if a lot of you all are patients or who know diabetics who are also patients, to emphasize prevention and early detection, because honestly, that is the best way to prevent some of the major complications that occur when we are talking about diabetes. So let's talk about epidemiology. Alrighty. So the global prevalence, and prevalence means the number of new cases, or I'm sorry, the number of old or existing cases of diabetic ulcers in diabetic patients ranges between 4 to 10%. And it's such a huge percent difference because we're talking about across the globe. So I'm not just talking about the United States or the Bahamas. I'm talking about across the world. So we're talking about 4 to 10% of the entire world, up to 10%, can have a diabetic ulcer at this moment. The incidence rate, that's the number of new diabetic ulcers, lies between 1 to 4%. So up to 4% of folks around the world are developing a new diabetic foot ulcer, which is extraordinary. And it is estimated that 19 to 34% of patients with diabetes are likely to be affected with a diabetic foot ulcer in their lifetime. So 34%, that's 1/3 of patients with diabetes around the world are likely to be affected with diabetic foot ulcers. And the International Diabetic Foot Federation reports that 9 to 26, and I know that's a huge disparity, but again, we're talking about across different countries, 9 to 26 million people will develop diabetic foot ulcers annually. And this is mostly because of the rise in diabetic population. And we'll talk a little bit about that in terms of the epidemiology, the increasing obesity rates, the reduction in socioeconomic status across some areas, and the low access to resources. So this is a slide that I actually really like. I mean, it doesn't, I'm actually here for a podiatry lecture, and I showed it to like a group of podiatrists because it's actually a market forecast of what diabetic foot ulcers are going to look like in the next 10 years. This is actually for these guys a good slide because it shows it's actually showing uh, a specific individual who's like, hey, what do I want to do with my life? Like, what kind of business might I want to develop? And they're like, hey, you might want to get into the diabetic foot ulcer business because from 2023 to 2033, look how much it's going to grow. It's going to be an $11.6 billion business in 10 years. So great for them, but bad for folks with diabetes. So imagine, and again, we'll talk about it in a moment, the amount of folks who are going to develop diabetic foot ulcers, the amount of cases that are going to happen, the amount of complications that were going to happen. And my job and Dr. Mitchell's job, and hopefully the job of everybody here on this call, is to stop that, is to help prevent this from happening and to make these folks very unhappy. So let's continue on and talk a little bit about what happens a little bit when you get a diabetic foot ulcer. Again, we're trying to prevent these diabetic foot ulcer, but one thing we really don't think about is the morbidity. And morbidity is, just a term that means the suffering that occurs, sometimes when you have diabetes. In the major aspects of suffering occurs, with infection rates. An infection is a leading complication, and it often progresses to cellulitis, which is infection of the skin. Abscesses are, kind of pus underneath the skin. Osteomyelitis, which is a bone infection, and sepsis, which is blood infection. If you're diabetic or have a family member who is diabetic, you're kind of in and out of the hospital. You have a much higher possibility of getting, infection rate, so, getting infected all the time makes it hard for you to, go to work. You might be on antibiotics all the time. You might have to be on new antibiotic time, all the time. So you're always incurring the costs of different medications, different types of medications. Is it going to be by mouth? Is it going to be IV? So it caused some level of suffering there with infection. Amputation rates, and that's 100% what we're trying to avoid. DFUs, which is the term we use for diabetic ulcers, are responsible for 80% of lower extremity amputations. I mean, there's other ways to get to get amputations. I mean, certainly traumatic ways, iatrogenic ways, but diabetic foot ulcers are 80% of those reasons, which significantly worsens the prognosis or what happens in the future. And we'll talk about it in a moment, but if you get an amputation, you are at greater risk of mortality. And we'll talk about that in a moment. Recurrence, which, honestly, I think this is the greatest part to increase the suffering of patients with diabetes, because it is extremely high, with 65% of patients experiencing recurrence within 3.5 years. And recurrence just means that ulcer continuing to come back. You think you got it gone. You've been to Dr. Mitchell's office week by week by week. You're a nurse. You go to this patient's home. They come to your office. It's been years. It's been months, and you're hoping that it's closed, and maybe you get maybe a couple days, maybe a week, but then it comes back, and then you're back at it again. Days to weeks to months, going through the same thing again. And it limits your ability to work. It limits your ability to, take care of your family. It limits your ability to do your activities of daily life, and honestly, I think that is the greatest, other than, amputation rates or some of the other aspects of the mortality, that is so difficult when you have diabetic foot ulcers. Next is that it can cause prolonged healing and hospitalization. Again, this is an aspect that can, again, lead to your not having the ability to work, not having the ability to complete your activities of daily life, not having your ability to take care of your family. Your delayed healing increases infection. You're in the hospital, increases costs, high, hospital bills. Again, those lengthy hospital stays, can lead certainly to suffering within your household. And finally, the psychological and socioeconomic impact of all of the above, which can cause significant burden on patients, families, and the healthcare systems, which I will discuss shortly. And then we're talking about mortality, which is another word for the risk of death. So basically, folks who have a diabetic foot ulceration have a high 5-year mortality rate. So 50 to 80% of folks with a diabetic foot ulceration will die. And with cardiovascular disease, often the primary cause of death. And typically it's amputation that will cause that high 5-year mortality rate. It's typically, after, if you get an amputation, in 5 years, 50% of the patients will have died. That's the typical rule of thumb, after you get an amputation. So we do our darndest to make sure that does not happen, and every time I do a kind of pitch for podiatry, when I'm on a kind of admissions tour, I talk to people and I tell them, your cardiologist saves lives, your, cancer doctor saves lives, but do you know that your podiatrist can save your life? And very few people are like, nah, but we really can. We really do. And honestly, we save lives every day, because we heal these ulcers and we prevent this 5-year mortality rate from these amputations that can occur. So with these diabetic foot ulcers, the common standard practices that typically occur, what we typically, as podiatrists, we will do some surgical debridement, which will cut off the dead skin and tissue. And if you've gone to your podiatrist's office and you're like, why are they always cutting it to make me bleed? Basically, we're trying to take a wound that's static, a wound that's just kind of sitting there, a wound that doesn't remember, that it is, nice, healthy skin. And we're trying to rev it up. We're trying to remind it, that it needs to heal. And in order to do that, we're giving it a jolt, so we're taking taking an old wound and we're making it a new wound. So that's why we're cutting it, and why we want that nice bloody red tissue. And the rule of thumb basically is, if it's bloody red, then then it's healing. If those are nice healing colors. But if it's black and grays and yellows, those are not healing colors, and those areas of the skin either need to be removed or assessed, in a vascular way. And I'll talk about that in a second. Another thing that we do is we assess, moisture balance. We use moisture balance dressings for exited control. So what that means is, when we're doing wound care, a wound can't be too wet or too dry. It has to be somewhere in the middle. So if it's too wet, we use a dressing that's going to dry it up a little bit. So if it's too dry, we use a dressing that's going to add some moisture. And it's, it takes a little bit of trial and error, a little bit of wound care knowledge to kind of know, that kind of happy medium when you're determining, wound care dressings. But once you got it, you got it. And then we're doing some offloading. Basically, if there's some pressure areas, and, if you've got calluses on the bottom of your feet, that's an area of excess pressure. And under that callus is going to be, either a bone or a deformity or something that is going to be causing some biomechanical pressure that can, if you're diabetic, lead to an ulceration in the future. So what we do as podiatrists, we pad those areas, or we can even, down the line, give you some footwear adjustments that can offload or kind of float that area to remove the pressures in that area. Circulation assessment and management is something that we do in conjunction with the vascular doctor. Basically, you need blood to heal any wound. So, if you've been to a podiatrist office, and I'm hoping that your internal medicine doctor or the nurse that takes care of you are checking the pulses in your feet to check for circulation, because without circulation, that ulceration is not going to heal. It does not matter what wound dressing you put on there, it's not going to heal. So we want to make sure that there is indeed circulation. So we make sure that we do assess that. We want to make sure that there is no infection. If the wound is infected, it's not going to heal. So there are signs of infection that we want to check. So for you guys, if the wound is hot, if the wound is smelly, if the wound is like, kind of boggy, if the wound has pus coming out of it, those things are not good. Those things, scream infection. So you either need to get to your podiatrist, your internal medicine doc, your nurse, or to your nearest hospital, straight away, to make sure that you keep that area, because a diabetic foot ulcer that becomes infected can lead to amputation rather quickly. We also want to make sure that your blood sugar is under control. And this is something that we do in conjunction with your internal medicine doctor. And I'm always, kind of in this give and take with my diabetic patients, because I'm always trying to explain to them that if their blood sugar is super, super high, it's not going to let me heal those wounds. It's just going to fight me back, so we got to get the blood sugar down to allow me to get these wounds healed. So we got to get them in a better balance nutritionally so that these wounds healed. Okay. So if your blood sugar is out of control, then we got to do something to fix that, so we got to talk to our endocrinologist, maybe get on one of these GLP-1s or a different type of diabetic medication, or increase our activity, maybe start going to the gym or doing some exercises at home to reduce our body weight. The rule of thumb is basically, if you reduce your body weight by 20%, it will definitely help reduce your blood sugar significantly, so that you can either reduce the amount of diabetic medication that you're taking, or sometimes even eliminate it altogether. So, I highly recommend, some movement if you aren't already doing so. We're also doing some footwear adjustments. again, if you've been to Dr. Mitchell's office, she has a whole wall of different type of diabetic shoes that you can get. And it's all because diabetic shoes are custom designed to offload those areas, to protect the feet, basically to make sure that the feet are protected from the outside world. And, and I am from Miami, so I know that it's sometimes tough to want to be in kind of a closed toe shoe all the time, when you're in the Bahamas. So sometimes you want to be in sandals or open toed shoes. So it's kind of tough. So, there's always a bit of, of a compromise that can be had. But honestly, I'm always like, do we want our feet or do we want our flops? Which one? Pick and obviously one is better than the other one. And then finally, what podiatrists do is we do surgery or limb salvage procedures on the foot and sometimes we have to do amputations, if it's really bad. But sometimes we even do, reconstructive surgery or, just to make sure that we help save that foot. But the best outcome is to occur in multidisciplinary diabetic foot clinics. So if you are the best team consists of a podiatrist, an internal medicine doc, if the podiatrist is not going to be your wound care doc, which, most of the time we are, but we definitely do refer out to wound care. Then we also have wound care nurses, which is also part of the team. Nutritionists are also part of the team, depending on if there's surgery. Physical therapists are also part of the team. Vascular doctors are a part of the team. Let's see. Oof. Am I missing anybody? I'm going to think about it. But it's a whole bunch of doctors that are involved in making sure that we're taking care of you in a holistic way. Sometimes we need an infectious disease doc, if we need to give you a specific type of, antibiotic, so there's always somebody on the case. And that if we've got multiple people, everybody has a part to play to make sure that you heal. No one's going to be able to drop the ball if there's multiple balls in the air. But unfortunately, despite comprehensive care, still significant gaps in healing and limb salvage outcomes still remain in some low-income areas and in areas that have low resources. So let's talk a little bit about some low-resource settings. So there are some system-level barriers that will cause these disparities. First, we have some lack of specialized care and infrastructure. And this is a little like the Bahamas, where we have fewer specialists like podiatrists. In the Bahamas, there's only 5 podiatrists. I mean, last year, this time, there were 4 podiatrists. So you have gone up by 1. So, which is exciting, but there's still only 5 podiatrists for the entire country of the Bahamas, which is why we still continue to do things like the Bahamas mission trip to kind of fill the gap between the time that patients are unable to see a podiatrist when they need one. The absence of multidisciplinary teams, and that is kind of congruent with the fact that there are fewer specialists. Again, in the Bahamas, there's 5 podiatrists, but there's only 3 vascular doctors. I mean, how many endocrinologists are there? How many folks are, specialized in nutrition or physical therapy or, infectious disease, to make those multidisciplinary teams for the almost 20% of you who are diabetic, and the 5% of you who have developed the diabetic foot ulcers. And there's some resource constraints. The Bahamas itself have resource constraints, with important exports. There may be just things that you just do not have here that may be more readily available in the States that will cause some constraints for your healing. But we'll talk about how that can be alleviated, in terms of some cost saving measures. In different areas, and I'm not just talking specifically about Bahamas, I'm kind of spreading out globally. There are some socioeconomic and geographic barriers that can lead to some disparities. And there are some areas where poverty and insurance, with low income status and and inadequate insurance coverage will directly correlate with higher amputation rates, and they create barriers to consistent quality healthcare. It doesn't matter, where we are. We can be in, the United States, we can be UK, we can be in Australia. There are areas, where they have poverty, and areas that have low income status that will cause these that will create barriers that will consistently reduce quality healthcare for the folks that live there, and lead to the disparities that will cause an increase in the amputation rates in that population. And there will be some geographic isolation. And again, I'm talking globally, so that there can be some areas that are just kind of far away from these resources. I mean, in the Bahamas itself, there are family islands that are quite a bit away from, some of the other major populated areas of the island that won't have the major resources that are available. Dr. Mitchell would know better than me what those areas are, but there are individuals that are living in a more rural area. We wouldn't say that they're, disadvantaged, but that they have, less or more limited access to some of the, more highfalutin, resources that are more readily available in more highly populated areas. And that can sometimes cause, again, create barrier to consistent quality healthcare. And so, because of the disparities in low resource settings, what is going to be important is going to be patient and provider education, which is why we're doing this. I mean, Dr. Mitchell does an amazing job with doing these meetings, because your knowledge helps us prevent you from getting these diabetic foot ulcers that will increase your risk of morbidity and mortality. So your lack of awareness about preventive foot care is going to contribute to poor outcomes. But that's what we're trying to eliminate, that lack in these types of meetings. We also do the same thing. We come to the Foot Fest, which is why we constantly have CMEs and education and lectures, because we want to eliminate the lack of awareness. We want to add, some education about prevention in healthcare, so that you become your own advocate in order to help reduce the poor outcomes that can come with lack of education. And there are certainly some racial and ethnic disparities. Within developed nations like the US, racial and ethnic minorities face significantly higher amputation rates compared to their white counterparts, a disparity that often overlaps with socioeconomic and geographic disadvantages. So this the impact on outcomes, leads to a disproportionately high burden of amputation and mortality rates in these disadvantaged populations. And the major amputations lead to a substantial risk of disability and premature mortality, with the reported 12-month mortality rate of 5%. I'm going to say that again. Within 1 year after amputation in different parts of the world, 5% of folks who have had an amputation will be dead. 1 month, 1 year, 12 months. And the 5-year mortality rate after amputation varying widely across countries from 50 to 80%, as I mentioned. So why does limb preservation matter? I mean, I mentioned this, we talked a little bit about that mortality rate already. I feel like that's a duh moment. We don't want folks to die. We want to save their limbs, because we don't want you to be dead in 5 years. So that, is a pretty good, already, something that we want to make sure doesn't happen. We want to increase your quality of life. We want to increase the socioeconomic status and reduce the emotional costs to families. And we want to reduce the impact on national healthcare spending. In the UK itself, the diabetic foot ulcers cost annually 837 to 962 million pounds annually for diabetic foot ulcers. In the US, $9 to $13 billion annually for diabetic foot ulcers. Billion with a B. And in Australia, it's 1.5 million billion with a B for diabetic foot disease in the overall healthcare system. Dr. Mitchell would know more than me how much diabetic foot related costs are in the Bahamas. I don't know if you have those statistics, Dr. Mitchell, but I would be interested in knowing. But, across the world, the impact of healthcare spending is significant when we're talking about diabetic foot ulcers. So countries nationwide are interested in prevention and reducing the amount of hospital related costs when it comes to diabetic foot ulcers. Not just that it's going to reduce mortality and morbidity for their patient population, which is awesome, but it will reduce their national healthcare spending, which is going to be great for that particular country. So why are costs so high? Diabetic foot ulcers cost a lot. I mean, it includes advanced wound care. I showed you guys in that slide. It's $11 billion projected business over, the next 10 years. Hospital stays, after super long, after amputations, medications are expensive. The specialists, I mean, yes, it's going to be better with that multidisciplinary team, but, you've got so many specialists, it does cost more. Amputation rates are going to be more expensive. The high rates of minor or toe amputation, but major amputations like legs significantly drive up the cost. And if you get a complication, those costs are astronomical. Spreading infections, skin or bone like osteomyelitis, and vascular issues add to the burden. And what if you need long-term care? If you need to go to rehab, if you need further physical therapy, that is more significant in terms of cost. Chronic wounds that last forever, and recurring ulcers require sustained and costly management. That's why things cost so much when we're talking about diabetic foot ulcers. So again, the national, healthcare system significantly wants to try and do something, to reduce the amount of diabetic foot ulcers and to help prevent them for some major limb salvage in different parts of the world. So what can we do in terms of cost-effective diagnostics and treatment? And some of these things you can actually do on your own, but I highly recommend that you get to a podiatrist office or a nursing office, your internal medicine office, but if you can get to one of the podiatrists here in Nassau, I do think that Dr. Mitchell, do you still go to Freeport, Dr. Mitchell?
Yes, we go to Freeport.
Yeah, then at least there, two areas, that have podiatry you can definitely get to. All right, so these are some of the first you have to figure out where you lie in terms of your risk assessment. So you need to get to some place that's going to be able to assess you. In the Bahamas, they actually have a very extensive method of vascular assessment in the local clinics. I'm just going to talk about, some of the ones that you can do or that are done more in a limited resource setting. Where you can do palpation of pulses. You're checking for capillary filling time, which is if you put your finger on the tip of the toe and it blanches and like how long it takes for that blood to come back. And, we time that and it should be less than 3 seconds. Skin changes when we're talking about vascular assessment. Skin changes like temperature. We want to make sure that temperature is nice and warm. We don't want it to be cold. We want to check with a Doppler. I mean, if you've been in a podiatry office or a vascular doctor's office, we can use a Doppler, the same thing they use, for an OBGYN's office to listen to a baby, to listen to your pulses in your feet, to listen to see if those pulses, sound nice and strong. And then we can do some pulse assessment utilizing a blood pressure cuff, and we've discussed this, Dr. Mitchell, to have like nurses trained, in different methods across the Bahamas to kind of do basic vascular assessments to make sure. But I think that you guys already kind of do really great, 60-second in low, to make sure that that's already done. So I'm good to go with that. There's also some neuropathy testing. which is nerve testing to just check how you're feeling. When you have diabetes, you have a high chance of getting some numbness, tingling, burning in the feet. So we want to assess that to see how bad that is. So we use something called a monofilament which is basically the gold standard. It's super easy to use. And most of your docs, your internal medicine docs, your nurses, your podiatrists are going to use that on you. And it's super easy to test. We also utilize a tuning fork to check for the vibration to assess your nerve sensation. When imaging is available, we utilize X-ray machines, which can be portable to assess underlying deformities. If you've got bunions, that bunions or hammer toes, if your toes are bent over, or a bone infection when we're talking about diabetic ulcers. We can use ultrasounds to check for abscesses, which are pus underneath the skin. And we can utilize portable machines for those, or you can utilize machines in the office of your podiatrist or your clinics. And then we definitely want to check, for the point of care labs like glucose, which you should be assessing every day to make sure your blood glucose is where it's supposed to be, your hemoglobin A1C. And we can also check your CRP, ESR, which are just values to check your infection, your possibility of an inflammatory status, which is just a measure of the possibility of infection. Okay. All right. So I'm not going to talk much about this. This is more for my healthcare workers in the room. This is more wound care classifications, because that's another thing we have to do. We want to make sure, we've assessed the patient. Then we want to assess the wounds. How risky is the patient? High, low, moderate, blah, blah, blah. But now, how bad is the wound that they have? Good, bad, in between. And there's different ways to classify a wound. And there are multiple ways, that we do it. So, I believe the Wagner classification, that is something that you guys utilize here in the Bahamas, which is the easiest thing. It doesn't give us the greatest information, but it's super easy. It's one that most folks remember. It's 0 to 5, 0 being perfectly fine, 5 being basically, gangrene, need to chop it off. And then we have our UT system, which I'm not sure that you guys use in the Bahamas. And I do not believe you guys use the modified Wi-Fi system. I think you guys use, I'm not sure, Dr. Mitchell, but I think the Wagner is the one that you guys use most often. But I think it's the most common use kind of around the world because of its simplicity. So I'm just kind of skip over these. But it is important to kind of classify that wound, because we want to make sure we know where we are. We want to, we don't want to put somebody who has a 0, no wound, with somebody who has a number 5 infected wound, kind of in the same category, because different things are done for both of those patients. So let's talk a little bit about some non-surgical strategies of what we're going to do about these wounds. So first, again, we've assessed the patient, we've assessed the wounds, and we're mostly going to be talking about, with offloading techniques, those wounds that are not infected, not gangrene, so those wounds that are kind of in the middle, so when we're talking about offloading techniques. So with offloading, this is what offloading looks like. I mean, if you've been in a podiatry office, you've kind of seen the podiatrist kind of take out this thick felt and, start doing, crafts, on your shoes. This is what they're doing. What they're trying to do is trying to, offload or float an area where the wound is, so that you're not walking on it. It is a bit of kind of trial and error to learn how to do. So if you're a nurse or another healthcare worker, I highly recommend you allow the podiatrist to do that, or to get your podiatrist to show you how to do this, because there's a little bit of work that, is done with how to adequately offload an area if you don't already know how to do so, because it can cause, some ancillary issues if you don't know how to do it. Offloading doesn't just have to be, kind of extra. It can also be built in to an orthotic or to a diabetic shoe. So that's also something that can be created, kind of within. So, I always find shoe offloading or orthotic offloading like much more effective because it's already built in and you don't really have to play with it. I already talked a little bit about footwear options in terms of diabetic shoes. And patient education is going to be, key, because if we give you guys, if we say, hey, you have to offload this, you've got this ulcer on the bottom of the feet, we've got it. The problem with it is because you have this kind of pressure area. We put this pad here, or we created this, shoe that has this little cutout here. You have to make sure you're wearing it. You're the one that has to do it. You have to do it. Honestly, like if you're like, yeah, but I don't feel like wearing it, I don't want to wear it, I don't like wearing it, it's ugly, the shoes are ugly, and the wound continues to come back, it makes it very difficult for us to get you healed and to keep you healed. And we honestly, we want you to be healed. We want you to be able to get to work, to continue on with your activities of daily living. But your compliance and you shaking hand with us and you actually doing what we ask you to do really helps us out. Alrighty. So let's just move on to some types of wound care and dressings. If I've got some, healthcare workers on the call, there are some locally available dressings, some of the honey-based dressings that are super easy. I mean, honey's been around forever. Honey is a natural antibacterial. I just have a photo of Medi Honey here, but I love using Medi Honey because it's actually super easy to get. Folks actually believe in it, because they're like, yeah, I don't recommend using like store-bought honey, like Dr. Hill says use honey. No, use medical grade honey. Don't use, honey from like the grocery store or anything like that. Make sure it's more of a medical grade honey. But that's going to support more of a moist healing to kind of, but it also is antibacterial to help, kill any bacteria in the wound. Also, iodine. I mean, honestly, iodine is kind of taboo in certain circles. They talk about it killing good skin, but honestly, I've used betadine for most of my life. And, as a resident, as a podiatrist, and it will kill bacteria, it will dry the area. I mean, it's such a versatile but very inexpensive way, to help me, if I'm in an area that has very reduced resources. So I use betadine. If you have access to negative pressure therapy, I also am a strong proponent of a wound vac. I mean, if you have access to it, if you can't afford it, I mean, it is an amazing thing, especially if you have a wound with significant depth. If it's really deep hole, a wound vac can do wonders, So if you have right now a wound and it has significant depth, I would get to one of my podiatrist's office to see, what I can do there, because that is definitely going to help you with that. I mean, there are other ways. There are other ways. There's, other wound care products, and the wound vacs are certainly on the more expensive side, but I am a firm believer in wound vac therapy to assist with wound closure. And this is more for, I don't necessarily use topical oxygen, but I think, for folks, hyperbaric oxygen is still something that is used out there. There is a portable method for topical oxygen. I'm not the hugest proponent of it, but it is out there, and it's still out. It's still possible to use. It's better than nothing, and it's still something that can be utilized for wound care. So, alrighty. So let's talk a little bit about some education. So for us to help prevent our limbs from being amputated. The first thing we have to do is what we're doing now. We are educating our community, we're educating our public. We are constantly educating the nurses and doctors and med students, but first line is educating you all, educating the public, giving you guys some knowledge and like, what the heck are you talking about when, we're talking about the severity, of diabetic ulcers when we say it can kill you. If somebody gets an ulcer in your foot, it can kill you. It's not like a diagnosis of getting cancer, but it is pretty serious because it can cause significant morbidity and like loss of job, loss of stability, loss of the cost of it can be significant. So just stopping it from happening in terms of education is going to be important. We also want to make sure that we train our healthcare workers. So if there are any healthcare workers on the call, we're happy to see you. And we love to make sure and to hear from you. If you have some questions at the end of the call, we'd love to hear from you. We want to make sure that you can adequately perform these foot exams and the assessments on these patients, and to adequately educate your own patients about their lower extremity ulcers so that we can reduce the incidence significantly. In the future, or maybe even now, I don't know if you use it now, Dr. Mitchell, but, in the States, we utilize some telemedicine or virtual medicine for remote monitoring. There are in different parts of globally, they utilize telemedicine virtually for remote monitoring. I have seen the technology in some respects. Some of them are amazing, where basically there's like a walking computer. Some of them are almost like my cell phone, and it's a little tough, to kind of see the wound and kind of assess it in that manner. So it just depends on the technology, but it'll just get better. Some affordable interventions are out there, some footwear that you can actually afford. Some are really tough to get. I mean, I was talking to a podiatrist the other day, and we were talking about, the things we can get on Amazon for patients, the things that are, comparable to the expensive, $100 diabetic shoe that, we prescribe for our patients who can't get it, so that we are definitely able to get those things. And then I already mentioned the telehealth and virtual health. And in future, AI is going to be a big deal. AI is going to be utilized, for triage, utilizing our smartphone. There already are out there apps that you can use to help you check your, cardiovascular status, to do EKGs, on yourselves with your phone. And in the future, you might be able to have an app that will take a picture of your diabetic ulcer and let you know like what stage it is, what you need to do. I mean, we're not there yet, but that might come in the future. But we're definitely not there yet. And I'm hopefully there may be some affordable biologics and substitutes. Right now, again, that $11.6 billion business is definitely pushing more expensive biologics and wound care products, which makes it difficult for us to get really high quality and more advanced wound care. So maybe in the future we'll be able to get some affordable ones. And then perhaps we can have more community-driven device manufacturing because, in that specific country, once they realize the scourge of diabetic foot ulcers and the amount and the cost of these ulcerations on folks' feet, they will provide some local production of offloading devices and footwear to help address the supply shortages and empower the communities. All right, these are my references. Thank you so much for your attention. Are there any questions?
Wow, Dr. Hill, thank you so much. Oh my goodness. I
I
was
felt
just
like,
going.
sorry
That
about
was
that.
a lot. Okay, so I saw a couple of hands went up. Thank you so much for a comprehensive presentation. And I'm sure we are going to have some questions to cover
You
some
told me
back.
40 minutes, Dr. Mitchell.
Okay, that's good. That was good. So I'm sure we will have some questions, and I can answer some of the questions that you asked in the chat during your that you asked during your presentation about our system. But I'm just going to invite everybody. If you have questions, go ahead and put them in the chat so that we can get those questions to Dr. Hill. So I can say yes, we here in the Bahamas, we have our system where we teach our nurses and our doctors to do what is called a diabetic foot screening. And that's where they will look at the foot and check the foot for their risk of getting amputation or ulcers. And we've done that for our nurses on all of the family islands. And we encourage them to do that so that, we can identify when we have somebody who is at high risk, and that person can be sent in to Nassau, or they can, family can bring them in so that they can be checked or get additional assistance in a timely manner rather than, just staying there. One of the other things I think you asked was on the islands, that what islands. So we do have podiatrists that travel. Me and Dr. Noel Zadley, I think, go to Freeport. Dr. Johnson, I think, goes to Eleuthera and Abaco. So right now, we don't currently have resident podiatrists on all of our family islands, but some of them do receive some service from visiting podiatrists. And then I guess other than that, persons would have to fly to New Providence to receive the service. But the screening is critical because that is what helps us to identify when we have a problem. And then we are working in a team approach, and that's where we have our primary care doctors as well and our nurses, because a lot of times we may not have a doctor on the family island. And we just ask that at every primary care visit, every time you go to the clinic, we tell our diabetics to take off their shoes and socks. Take off your shoes and socks because that reminds the primary care doctor or the nurse to look at the foot. They're very busy as well, so they may forget, or you have a lot of patients sitting in the waiting room, so you may not get down to the feet. But simply taking off your shoes and socks helps to remind them to take a peep at your feet. And that simple thing right there can actually save someone's legs or save their feet. And then, of course, from our statistics we hear, it can actually save their life. So we're doing some things, and we're hoping that, our partners, our nurses, our doctors, our other health professionals who are on board can actually assist us as we do that as well. I see we have one question in the chat. Um, can I use aloe on my sore? So it sounds like this person has a wound and they want to know if they can use aloe on that wound. Do you have any thoughts on that? And I can probably say something as well. Dr. Hill?
I hesitate to give medical advice when I don't see the wounds, when I don't know anything about the wounds. I haven't seen the patient. So I don't know.
Okay, that's
I know
it.
you can use aloe on good skin, but I can't really speak to aloe. Like, what if it's infected? What if I don't know.
It's deep. Yeah, so that's an awesome answer. So it's very difficult to give that type of advice. So I would recommend that that person who, if you have a wound, it's best to go in and see your podiatrist and have that wound assessed, and then we can make recommendations as to what would be the best thing to put on that wound. But we can't just say yes or no to putting aloe on the wound. Aloe does have healing properties, and it is indicated in certain things, like Dr. Hill just said, intact skin for moisturizer and also for superficial scratches and stuff like that. But we definitely cannot just blanketly say that, yes, you can put the aloe on your wound. So do you have any other question? I saw um, um, oh goodness, Dr. Knowles. What's her name? Not Rebecca. I saw she had a hand up earlier. Hold on one sec.
My apologies. I couldn't see the.
Let me chat. Okay, so I see that definitely. So we also see, I see Nurse Brown is here as well, and she usually does a lot of stuff with papaya. So that's also another important product that persons like to use. And so I will just invite Nurse Brown to just say something about how persons can use papaya on their wound. And then we have okay, so I'll answer this question. Take this one to Dr. Hill first, and then Nurse Brown, you can just mention if you had anything to mention about the papaya, um, um, after this, after you answer this question. How does walking bare feet on cold tile affect the diabetic foot? Dr. Hill,
Okay.
I
So
would.
the whole idea of diabetic foot protection is protection. So, in your house, we recommend that you're wearing some type of shoe gear, bedroom shoes or flops or something, because ultimately what we don't want to happen is that you scratch your feet, you have a sore, anything. If you are in the habit of looking at your feet every day, if you have really good sensation, your blood sugar is great, then I don't have a problem with you walking on your feet on cold tiles. I have no problem with that. But if you're a diabetic, you have poor sensation, you then I would definitely say that that's not a good idea, because then you're at greater risk of it causing a break in the skin that might lead to an ulcer that can become infected, that can cause problems in the future. So it's all about just kind of protecting your feet. When and if you get to a podiatry office, they'll tell you the same thing. It's going to be looking at your feet, checking daily, cleaning, using lotions, all of those things that are going to help moisturize the skin and protect the feet from any type of complication in the future. Hopefully that answered your question.
Yes, but we say do not walk barefoot at all. And socks is barefoot. Because
Oh,
if you got
okay.
stuck with something by walking barefoot, whether that's a tack, a nail, a pebble, or whatever it is, it's going to go straight through that socks. And in fact, we don't even recommend the cloth bedroom slippers, because if you step on something sharp, it will also go through that slipper. So the best thing to wear is an actual slipper that has a sole that you can wear in your house. You want to keep it clean. Don't walk in it outside. Put it right by the door, and then you just use that inside. But no barefoot walking. I'm not as confident as Dr. Hill. So I just say no. Don't walk barefoot. Whether that's no matter, whether you have good sensation, whether you have good circulation, whether you have whatever. Because the habit you develop when you have these things is going to be the same thing you're going to do later in life when you don't have the good circulation, when you don't have the good sensation. So it's best to do the right thing from now. So you learn that from now, and then you will continue to do it. So no barefoot walking for diabetics, no soaking your foot in hot water, no bathroom surgery. So if you have something wrong with your foot, you go and see the podiatrist. No digging and cutting and pulling and pushing, um, trying a scissors on a kitchen knife and all these things that people do to their feet. Don't do any of that. If you have a concern, you go and see the podiatrist. Don't wait. Just go as soon as you can. Delay is one of the reasons why we have so many amputations and so many bad outcomes. Because when persons don't feel, they take a longer time to come to the doctor, and then they have bad outcomes because we can no longer help. If that foot is, if the bone is infected and it's swollen, it's red, it's hot, and all these things are going on, then we have a less chance of saving that foot than if somebody comes early. In fact, the research shows that a podiatrist visit, just seeing a podiatrist before any problems, just this is a routine visit, seeing a podiatrist will decrease the amount of persons who get amputation, who get ulcers, and who go in the hospital just by seeing your podiatrist. So that's why we recommend seeing the podiatrist at least once per year. And that's before you have any problem. So we just see them once a year. And once you come in, we will do that screening that Dr. Hill was talking about. We will risk stratify you, and then we will tell you how soon you need to come back. It may be 3 months, it may be 6 months. If you're really, really good, it may be 12 months. And then after that, then we will be able to monitor you on a regular basis. But no barefoot walking.
Listen to
Okay.
Dr. Mitchell.
Thank you.
Yes. Nurse Brown, did you want to say something about the papaya? And then Justina Knowles, I think. I don't see her anymore. I think I saw her hands up earlier. Knowles. Okay, I don't see her anymore.
Okay.
Okay, Ms. Brown, go ahead.
Good night. I'm Ms. Brown, formulator and manager for Papa's skincare products. And one of the main products that we manufacture is the papaya paste. Now, the papaya paste would have been used many years ago for exfoliation of wounds, and we continue to use in some instances even today. Again, it's only made upon request if needed. And like I said, it's an excellent exfoliator, and persons who would have used it could attest to that. In addition to that, other products are also used, made by Papa's Skincare, that helps the diabetic to keep the skin moisturized. And so if you're interested, my contact 434-6033.
Okay, Nurse Brown, you can also put that in the chat for us because some persons
Okay,
may
not a problem.
want to get in touch. So put it in the chat for us.
Not a problem.
Awesome. Thank you so much.
Appreciate it.
So Dr. Hill, one
Is
last
it like
question.
a breeder or Santo?
Yes, so it's similar to that. We've had patients that we use it on, that we've used it on wounds that would be very similar to the Santil. So it's the papaya, papinuria, the enzyme. But you know, a lot of persons use the papaya hair, which I thought Nurse Brown was going to talk about. But a lot of persons use the papaya hair, and what they do is they just grate the whole fruit and kind of crush it and put it in their wound, which is not the way that it should be used, because the enzyme that actually debride the wound is only under the skin of the green papaya. Is not in the fruit, the fleshy part, the white part of the fruit. It's not there at all. So if you're grating your papaya and put it in the freezer and or scooping it out or whatever it is, and to put on your feet, that is not doing it. That is not going to do it. The enzyme is actually under the green part of the skin. And so that is what is effective. So I know a lot of persons, some I've heard that a lot of persons who go to PMH and other places use it. So that is something that, and I think we're going to do that continuing education again. Nurse Brown did an awesome job on that a few years ago. And I think probably we're going to get to do that again this year, because we like to educate persons and let them know what is available out there and how they can use it. And you know, here in our country, we're big on using natural products and using the bush and everything that we have locally. But we want them to use it safely and intelligently. So we will definitely plan to do that again, Ms. Brown. Just accommodate us. We're not sure yet, but we'll look forward to be doing that again. Okay, so I'm going to open up again. If we have any other questions in the chat, or we have any other persons who have a question they would like to ask a question, you can raise your hand at this time. If not, then we're going to be moving toward closure. So, and this year we can confirm that we will not be having Foot Fest this year. Sadly, we will not be having it this year. So hopefully we'll be back on track next year. So we will definitely be continuing our education sessions and for our patients as well as for our healthcare professionals. But this year we will not be hosting Foot Fest in country, not unless something happens in the next few weeks. But so far, it will not be happening. So we're looking forward to next year, but excuse me, when we can be back on track. So, okay. So one last question, Dr. Hill, and what would you So you mentioned a lot about the multidisciplinary team approach and how effective that is in countries like the Bahamas or in small countries like this. What recommendation or what would you say? How can we form these teams and get them going? How can that be done? We know in big medical centers and stuff like that, they generally have limb salvage teams and they have, everybody there. What would be your recommendation for an area like the Bahamas or other small island nations or states?
I think that you guys are in a perfect position though, to because you are small. I mean, there are 5 podiatrists, there are 3 vascular surgeons, just 3?
I think 4,
4, okay. How many endocrinologists do you have?
maybe 4.
Okay. I'm sure are there nutritionists, physical therapists, orthopedic surgeons? You know, I I would think maybe starting to have maybe a kind of a call for, through the ministry, like a diabetic, group meeting, kind of a national, to have, to give pride of place to all of these specialties, to have a meeting, to discuss, like, all of us together are needed to help reduce the amount of amputations in our population, because studies show XYZ. So how can we do that? So, and then come up with a plan, come up with a strategy, with the ministry, because I think it's going to have to be ministry driven. That 3 or 4 or 5, like the 5 of you will be at one location seeing patients this period. 5 of you will be at one location seeing patients this period. So that there will be a constant, you know, maybe
Okay, awesome. I think that's an awesome idea. And I actually, as you said that, I remembered when I was a young health professional in my young days, when I first came into the working in health, in public health, we actually had a system like that in the government clinics where the podiatrists and I was a health educator at the time, the health educators, the nutritionists, the internal medicine doctors, everybody would be at clinic at one time. And so that
mm-hmm.
patient would go from room to room to room and
Mm-hmm.
see everybody. And then at the end, when they left, they will have seen all the specialties that they needed to see.
Mm-hmm.
And I think that is an awesome idea. And it's something that's doable. So I will definitely advocate for that, to see if we can get a group meeting and begin. Dr. Farquharson and Dr. Lucas and Dr. Sands and all of them are very passionate about saving the diabetic limb. So I'm gonna advocate for that and see how we can do that. I like what you also said about having that group meeting. And then I thought also that research is important because we don't actually have the data that we need to make these decisions. So that's the next step. So thank you so much, Dr. Hill, for an awesome presentation and also bringing to focus for us the importance of the multidisciplinary team and, of course, involving the patient as the center of that team and to make sure that we are all focused on preventing these limb loss and saving lives. Thank you so much, so much. And I did neglect to say that we are both attending the International I can't remember. I know it's
International
AF.
Foot and Ankle Foundation.
Okay, yes. The International Foot and Ankle Foundation podiatry meeting that is being held right now in the Grand Hyatt. And so we have a whole team of podiatrists that came from all over the United States and Canada who are attending this meeting, who are actually hosting this meeting here in the Bahamas. And we were privileged to attend and actually to speak at that conference. So we're very, very pleased that we're able to do that. We have one more question. It says, what products are out there that can be used to sweeten food or tea? Oh, natural sweeteners, you mean? So, of course, any sweetener. So whether it's regular white sugar or turbinado sugar, it's still sugar. So that's going to affect and honey is also going to even agave. Every sweetener is going to have some effect on your blood sugar. And so the best thing to do is, if you can use those things without sugar, like tea or your drinks or whatever without sugar. That would be the absolute best thing you can do. If you need to transition, then you can use less. Okay, so you can just say, I'll put a half a teaspoon or whatever. If you're coming from 5, then maybe you may need to put 1 and just keep working your way down. Your taste buds will adjust. There's monk fruit. There's also agave. Those are natural sweeteners, and they are available at usually at the health food stores. You're probably not gonna find them at the regular food stores, but at the health food stores, you can find those there. I tend not to recommend like artificial sweeteners, um, because that's just my personal preference. So I would say the natural sweeteners like monk fruit or agave nectar that can be used. But of course, they are sweeteners as well. So they must be used in moderation, or even best to just use regular sugar, but keep getting less and less and less until you don't need it anymore. So that should be the goal, that you don't want to add it. You can also use fruit. If you want to sweeten something, you can just cut up some fruit and put it in there and use that. You can use dates as well, the fruit. So you just use the dates and you blend it. Sometimes if I'm going to make hot chocolate or something like that, I would do that. Blend the dates and put it in there. So that gives it a little sweet taste. It's not going to be powerful like sugar, but it will give it a sweet taste. So I use it to bake with as well. So those would be my best recommendation for sweeteners, that natural sweeteners that you can use. I hope that answered your question. Okay, awesome. Thank you so much. So now we're going to ask Elder Papal to come and give us our closing prayer. If we don't have any more questions, I just want to write in the chat. I'm going to put our office number here at Family Foot Center. So in case you need to come in or need to find out any more information, we are happy to assist you and to be able to help you with that. So we have our numbers here in the chat. And then also, we're at the time, we're going to ask Brother Paul to give us our closing prayer so that we can end the meeting tonight.
Father in heaven, we thank you for your word of encouragement. Thank you for the gift that you have given these doctors to share with us. As we leave this meeting, dear Father, but not your presence, help us to take this word with us and apply it to our lives so that we will live a long, healthy, productive life. Is our prayer. In Jesus' name we pray. Amen.
Amen. Amen. Okay, so the numbers are in the chat. So if you need to get in touch with us, our phone numbers are there. And we just want to say good night to everyone. Thank you so much for coming. And we have this meeting every month, the third Thursday of the month. Actually, it's the second Thursday of the month. We're on the third because of the holiday and everything. But the second Thursday of every month, the login information is the same. We don't change that. And then if you miss a meeting, you can actually go to our YouTube channel and watch the meeting over, because in another couple of days, we'll have the meeting uploaded. And I guess it stays on Facebook for about a month or so. So you can also go to Facebook and watch the video there. Thank you again, Dr. Hill. Thank you, Elder Papal, and thank you everyone for attending. We had a wonderful meeting, and we look forward to seeing you next month right here at 7 p.m. on the second Thursday in February. Thank you all so much.
Thank you, Dr. Mitchell.